Making decisions and taking actions, pharmaceutical competence, complexity, and culture. Hello, I'm Ejaz Hussain, and I'm pleased to share some thoughts on the importance of professional development in the context of 21st century pharmaceutical quality and cures. Section 1 will lay out a big picture, context, and provide some background information. The summary of the information I wish to share with you is as follows. Discussions on pharmaceutical competence, complexity, and culture is to know how to make good decisions and to take actions. This discussion is placed in what is known as experience economy. We'll describe what it is as we go along. And it is placed particularly and specifically in the context of 21st century quality and cures. I had the privilege to lead the US FDA efforts on 21st century pharmaceutical quality. So it refers and anchors this discussion in the developments that have occurred in pharmaceutical quality, particularly in the US and in the ICH, specifically ICH Q8, Q9, Q10, and Q12 guideline. The number 12 guideline is still a draft. But it also places this discussion in the 21st Century Cures Act, which was signed into law in December 2016. This is a very important law in the US and it will have a profound effect on drug development, and it will have a profound effect on how we assure quality in the future. The heart of the matter is we can and must do better. To do so, we must focus on professional development for all. We must do better to serve the interest, meet the needs and expectations of patients in the 21st century in the context of real world evidence, which is becoming a requirement in the US, Europe, and I expect this will happen all over. The discussion to follow focuses entirely on professional development as the central theme. What is professional development? Professional development is to go beyond our education and training to be self-authored in what we know and how we know it. This is how do we know what we know is a term which I will use again. It's called epistemology. The basic theme here is quality assurance is becoming a very important need, expectation for the patients. And to give anybody assurance, we must be self-assured. Without us being self-assured, we cannot give assurance to others. Now, there are many challenges that we face and that contribute to our inability to provide adequate assurance of quality to patients. I'll call these as common causes of many of our challenges, and will place this discussion in inadequate satisfaction in adherence. This is important, as you will see as we go along, to find a common thread that is common to patients as well as to professionals. Adherence to prescriptions, adherence to good practices, adherence to policies and procedures is that common thread, and how that common thread can be leveraged will be an important considerations in our discussions to follow. So let me give you some information that essentially provides the context and paints the big picture. Experience economy is a term that was introduced at the end of 20th century through a publication in Harvard Business Review. And the title of that publication was Welcome to the Experience Economy. What is experience economy? Look, we went from manufacturing to service industry sector, and from service now we are in experience economy. Our experience, how we feel, how we connect with things on our iPhone, our experience is valuable, and our economy is now centered around our experiences to sell us products, to influence us, and to really make experience the foundational basis for our economy. Now, in the world of IT sector, in the world of social media, in the world of consumer products, I think we just have to look around ourselves and to see how our behaviors have changed, evolved in this experience economy. There is a significant impact on the pharmaceutical sector also, and how that is evolving is a topic we will discuss. But also at the same time, what we have to realize that in this experience economy, experience, let's define experience. Experience is practical contact with an event or something in the material world. But experience as a verb deals with or signifies how we feel our emotions. Emotions and feelings are not often not rational. They are subjective, and that creates a dilemma that we will evolve further. But it is also what makes us or can make us irrational. And in terms of economics, Professor Kahneman received the Nobel Prize for his work in behavioral economics in 2002. And more recently, the 2017 Nobel Prize went again to uh, behavioral economics. What we see today is end of rational economics, and that has a profound basis for this. At the same time, one can argue average is over. Now, we assume normal distributions in what we do, but the reality is when it comes to experiences, when it comes to feelings, when it comes to therapeutic outcomes that patients experience, when it comes to placebo and nocebo effects, we are not in a normal situation in many cases. And here Pareto distribution applies, and Pareto distribution, if you see that, has a different tail. It's not a normal distribution anymore. And as a result, we are seeing and observing aspects in the marketplace where color and shape of generic pills has become important. Placebo effects are exploding, and side effects are skyrocketing. As an example, for levothyroxine, when the new formulation that are introduced are less variable, more stable, and have gone through a more rigorous bioequivalence assessment. So that's really an aspect of experience economy that we want to think about. At the same time, experience economy means user experience. User experience is very familiar in the IT section, in the device sectors. User experience we often also use for drug device combination, for testing of acceptability of a drug device combination and so forth. But let's keep it in a broader term here. User experience in experience economy is showing us significant challenges that we have to recognize and confront. There is exponential growth in overdose deaths. Now, this is very scary because last few years we have seen a blip in that exponential curve because of opioid related deaths. Last year, the numbers around 65,000 Americans died, and before that, 56,000. So each year in America, more people are dying of opioid related overdoses than the US lost in the entire Vietnam War. This is how serious this issue is. But this exponential growth in overdose is not just opioid, is other drugs, and it is related to many other drugs, legal and illegal, prescribed and non prescribed. And this paper, which was published a few days ago in Science magazine, really gets to the heart of these issues. uh, Approximately 170 or almost 177, or I don't remember the exact number, people die on a daily basis. This is really a reflection, I think, of inequality, insecurity, which is pushing the exponential growth of overdose deaths in the current state. This state is untenable. Inequality in terms of income inequality is significant. We now start talking about 1% and 99%. Many say the middle class is disappearing in advanced countries. I can see the challenges in India. There is, at one hand, enthusiasm for growth. India is growing in the middle class. But at the same time, at the tails, I see poverty like never before. And I see more of my the people I advise in India are billionaires on the Forbes list. So the inequality divide has increased so much. And that worries me. In this sense, it worries me. I think it is easier to tolerate income inequality, but it is not tolerable to have inequalence in therapeutic inequalence. I think that's where I'll take the discussion to. In America, medical errors are the third leading cause of death today. And insurance for medical care, which many cannot afford, I think is a topic of significant concern. In the pharmaceutical sector, we will get deeper into these issues. I'll just share one example right now. Frustration over ongoing drug shortages. I was at FDA in 2001, and that 120 number was on my mind. We worked hard to reduce it. I left FDA in 2005, and I've been monitoring this scenario. Almost all of these drug shortages are due to manufacturing difficulties, and this is unacceptable. More recently, frustration of has continued. More recently, American Medical Association, in fact, in June of 2008, adopted a policy declaring drug shortages an urgent public health crisis, and we'll get into this aspect later on. Now, I'll take you back to just the end of the 20th century when I was at FDA. We can do better was that theme in our minds then, and we launched the FDA's 21st Century Initiative, starting with process analytical technology and then pharmaceutical CGMPs for the 21st century, a risk-based approach. This our What FDA launched happened a year after the Institute of Medicine had launched its paper, To Err is Human, Building a Safer Health System. Now, these two initiatives, FDA initiatives on quality and the Institute of Medicine efforts on building a safer health system, converge in the 21st Century Cures Act in December 2016, and is now creating an opportunity and hopeful signs that we can start turning things around. But the fundamental issue which Institute of Medicine has identified is us, our our development. So, for example, um, to be a physician, you go through extensive education, training, certification, licensing, residency, fellowships, and so forth. Despite that, Institute of Medicine came out in the year 2010 and essentially said, we better rethink our education and training because it is not working. When the third leading cause of death in America is the healthcare system, medical errors, how can we say our education, training, and experience is working today? It's not. And Institute of Medicine, the report in 2010 called for a revamp. It called for a continual professional development because it is learner driven, allowing learning to be tailored to individual needs. So education, training, and professional development is a key. And about a month or two ago, a workshop report was published by the National Academy of Science and Engineering and Institute of Medicine. A design thinking systems approach to well-being within education and practice is becoming key because the burnout rate, the error rates are not decreasing. And why is that? So how does these efforts in 2018 relate to quality by design, relate to systems thinking that ICHQ10 brings forward, and how can we bring these pieces together for our own development is really an important topic we will discuss. Let me then sort of put this in a context, in a very practical context, in a day-to-day activity. Current good manufacturing practices in US are based on the assumption of adequate education, training, and experience. In fact, the regulation at 21 CFR 211.25 has those terms, education, training, and experience. It was written in 1977. When I looked at that more recently, especially in March of 2016, and I came to the conclusion that it is no longer on a solid theoretical foundation, nor can it be expected to have a rich practice experience. And I posted this on my LinkedIn page. So the title of my talk, my blog was Education, Training, and Experience and 21 CFR 211.25, Theory, Practice, and Epistemology. I'll come back to that, why I am so keen on epistemology for most of my career. This is the word I have used again and again, but I need to put this in very practical terms for you to be able to use it as to develop yourself. And we will do that over the course of the few sections that we will talk about. So let me remind myself, heart of the matter is, I believe now, and I know now that we can build and maintain effective pharmaceutical quality management system. I'm using the acronym PQMS. When every pharmaceutical professional is empowered to contribute towards improving the system they work in. Pharmaceutical quality management system is a ecological system. This is fundamental, and I think we want to understand the different types of systems that they are. And not knowing the different types of systems is a source of many mistakes we do. And I think this we will focus on. A way I know to improve PQMS from within while working within the system is to illuminate parts or paths to professional development for all to leverage fractals at every level in every corner. Fractals is a amazing opportunity, and I'm borrowing that term from the fractal approach to quality management system at my hospital. I have been ill last year and been in the hospital, and I had the first hand to observe what is a fractal approach to quality management system in the Johns Hopkins Hospital, which is, I believe, the best hospital in the world. And we'll bring that concept forward to what would we look like, what would it be in terms of pharmaceutical quality management system. This presentation and this other presentations you'll have describes my experiential learning to explain why I know and how do I know what I know, and what you can do to verify or validate this information at your level and in your corner. I think this is fundamental because only you can develop yourself. I cannot. I can share with you as passionately as I can my experiential learning. Why do I feel the way I feel? I think is important. And but at the same time, being objective, being professional is to be objective, rational, fact based, evidence based. You have to verify the information you get. As an introduction, I have just used my website, LinkedIn profile here, and you can visit me on that. But the key is this: over a month ago, I changed my profile to show my commitment to professional development. Building and maintaining an effective pharmaceutical quality management system and professional development are my key focus, and this presentation is part of that. So development of good practitioners is essential to make sure we do the right thing at the right time, but we also provide the assurance. Assurance is confidence that patients, providers need in our products and in our evidence. Practice is actions we take repeatedly. Action is conscious, reaction is subconscious. To err is human. Uncertainty stirs unease and insecurity. The outcome is irrational reactions. We learn by trial and error, that is research, in a broader sense. A map of ledges in our mind, marking actions and reactions is knowledge. First do no harm is a professional principle. So we first do research that may harm others in a laboratory to prevent harm. Care is research because it increases knowledge. Knowledge has power to heal and harm. Wisdom is to do no harm, do the right thing. So what is right and what is good is what we when what we do does no harm to others is right or and good. And wisdom is application of our knowledge to do no harm, but at the same time make progress. We have to have the assurance because no action is harmful itself. So we have to, wisdom is in action. So the key phrase that I sort of will underline my discussions with you is care is research, knowledge is power, and wisdom is in practice. So think about that carefully. It may not sink in or it may not resonate with you right away, but give it some thought. And I think we will come back and evolve that discussion to see whether my statement, collection of statements, care is research, knowledge is power, and wisdom is in practice, can be the backbone or the central theme of our discussion. So let me define professional development a bit more. Professional development is to go beyond traditional education and training, to be self-authored in what we know and how we know it, to be self-transforming in filling gaps between what we know and what we can implement. It is to feel the need and know the ways to leverage our collective experiential learning and understand the context of our abstract nouns by increasing our order of consciousness. Profiteer to patient to professionals to good practitioners. A profiteer who learns to be patient develops to become a professional. Now, you would have realized by now is I'm embracing all of human aspects within ourselves. I'm not aiming to say this is evil, this is good, this is criminal. I'm not in the mode of any finger pointing. Everything human is within us. We all are profiteers. Whenever we register for medical intervention, we all are labeled and coded patients. as a patient. And we all yearn to be professional, and we all yearn to be good practitioners. That's common to all of us. So why point fingers at anybody? Embrace everyone. So I would convert every aspect of human nature as part of the professional development. Now, much of the discussion to follow is inspired by many people, or the works that have occurred before me. Rumi's Elephant in the Dark, Dr. Deming's contributions, the Institute of Medicine's report starting with To Err is Human in 1999, Fractal Approach to Quality Management Systems at Johns Hopkins in Baltimore, and Professor Keegan's Orders of Consciousness as introduced in his book In Over Our Head in 1995. So that brings a constructive, psychological, constructive development theory of adult human development. So we will evolve a criteria to identify development needs and how to develop ourselves based on science, based on evidence, not just what feels good. So suitability and capability for a pull system. Professional development in the context of suitability and capability, like this, in analogous to what we talk about suitability and capability of a manufacturing process, suitability and capability of pharmaceutical quality system, we will use the same know-how, knowledge to seek out suitability and capability for professional development. And we'll place that in the context of 21st century pharmaceutical quality, from biopharmaceutics classification system to process analytical technology to quality by design and so forth. And we will have this discussion in the context of real world evidence, in the context of 21st century Cures Act, by way of real world validation, internal validation, self-assurance, assurance, availability, and affordability. So the prescription for all of pharmaceutical professionals across the global supply chain is professional development. A profiteer who learns to be patient develops to become a professional. Anyone who registers for medical intervention is labeled or coded as patient is a common theme we will adopt. An effective pharmaceutical quality management system, and the acronym P in PQMS has a emphasis on P. The P's in this acronym are pharmaceuticals, which by definition must be better than placebo, pharmacon, posology, pharmacology, pharmaceutics, public health, policies, procedures, and practices. Profiteers, patients, professionals within us. So our discussion, we will seek to align the P's to meet the 21st century real world needs and expectations of profiteers, patients, and professionals. So the common cause, I think, of all humans is satisfaction. Now, satisfaction, pursuit of happiness, satisfaction, liberty, life, liberty, and pursuit of happiness is really a common human need. It's a common human right now. So satisfaction and adherence is a key challenge that we face. So the interaction between the 21st Century Cures Act, IOM efforts and so forth, and the pharmaceutical quality really comes down to patient satisfaction. And adherence, the behavior of adherence, I'm using adherence, not compliance, and we'll come to that in a minute. Adherence is an important consideration. And competence, complexity, and culture, education, training, and experience, epistemology brings together a way to understand how do we deal with common cause. So let me summarize. Section 1, key takeaways. Aligning our many P's is needed to meet 21st century real world needs and expectations. Common cause of many of our challenges is inadequate satisfaction in adherence. Anyone who registers for medical intervention is labeled or coded as patient. We all are patient, but we don't take time to reflect on this fact. Profit is not bad as long as it does not harm others. Profiteering harms others. A profiteer who learns to be patient develops to become a professional. Professional development is to go beyond our education and training to be self-authored in what we know and how we know it. We give assurance to others when we are self-assured. Care is research, knowledge is power, wisdom is in practice. And that context gives us a way to ask new questions to organize the following sections. Identify development needs in the CGMP context, empower our self-development, satisfaction of expectations and quality assurance context, bring attention and work together on common causes. You can do that in the context of effective corrective action and preventive actions and systems thinking. Make risk-based decisions in the context of a quality scorecard, which Professor Byrne, Carey are evolving, and we can connect to that. Enhance patient centricity, expectancy of quality assurance in quality by design. We'll do that with case examples of generics and biosimilars and continual improvement in the context of patient complaints and pharmacovigilance. So the next few sections will come about building on these questions, and I look forward to sharing these thoughts with you then.